acknowledging, and we are being recorded. I'd like to start by acknowledging that the BCCSU is headquartered on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and that I personally am calling from the unceded ancestral territories of the Lekwungen-speaking peoples, including the Songhees, Esquimalt, and Wasanic nations. So today we have two presenters, Dr. Paxton Bach, who is an addiction medicine physician, and he's also the co-medical director here at the BCCSU, as well as Guy Filicella, who is a peer clinical advisor at the BCCSU, in addition to a variety of roles he plays. You'll also see a poll on your screen, and this is just to give us a little bit of demographic data to understand where you're coming from and what your experience with risk mitigation is. So we have an hour and a half together. Which sounds like a lot of time, but we do have lots to go through as well as time for questions. So we will start by giving some background and context around risk mitigation and how it relates to the current documents. And then we will go more in depth into the risk mitigation update, what has changed, what's the same, the new document, Opioid Use Disorder Practice Update, and how they both relate to the provincial prescribed safer supply policy. There will also be a few case studies, and we will encourage your participation in terms of questions and comments. And then we will discuss some resources available. And finally, we've planned a fair bit of time so that we can have a really robust discussion with questions for the presenters. So I will be moderating, and really what that means is if you have questions either as we're going or during the case study session, please just put it into the chat box and then I will bring it forward to the presenters. And with that, I will turn it over to Dr. Paxton Bach.
Thanks, Josie, and thank you everyone for taking the time of your day to attend. I'll apologize on behalf of Dr. Ruby Brower, who was supposed to be co-presenting with me today, but had to unfortunately extend her regret. So I'll be presenting her component of this as well. And if there is any questions that I'm unable to answer, we better fielded by Ruby, please let us know how we can follow up with you, and we can certainly do that. Before we begin, I just wanted to, one thing we wanted to ensure that we addressed right up front is just an issue with the PDFs that were circulated that was raised by a number of people in the province, just with regards to the opioid use disorder update and a table at the end outlining the medications that were included. So as I'm sure you're all familiar with, the documents speak very specifically around safe supply of hydromorphone and MS-Lon and what we've learned using these medications and where we're going with those. Many of you have noted that in page 24 of the opioid use disorder update, however, a table was included that mentioned a variety of other medications of other opioids, including sufentanil and oxycodone, that included stimulants and included medications that weren't otherwise spoken to at any other point in these documents. This was included at the request of the Ministry of Health based on their provincial safe supply approach. It has to do with medications that they want to see the SA code added to prescriptions and that are written in the future for these medications. So we're never intended on applying to the actual guidance that were included in these documents, but that has caused some confusion. So we have amended the documents. We removed those tables entirely. Apologize for any confusion. To be clear, we're not speaking any further at all about medications like oxycodone, sufentanil, or some of the other categories that were included there. We'll focus on hydromorphone, MS-Lon, as well as some of the prescription psychostimulants and benzodiazepines that were originally mentioned in the risk mitigation document. So I hope that helps clear up any confusion, and our apologies for that, but know that feedback's being taken up swiftly, and those amended documents should be available on our website imminently. I think we can circulate to our audience as well. So with that, Lisa, if you can go to the next page. So Guy and myself will be going back and forth the rest of this presentation. I'll start off by providing just a little bit of context that, again, you're all more than familiar with. So as you're all well aware, the WHO declared a pandemic March 11th, 2020, and much has changed since that time. Our public health emergency began shortly after that, related to COVID-19, and the pandemic and the resulting policy changes that have come from the pandemic have certainly exacerbated the existing overdose crisis that was originally declared in 2016. So a lot of this guidance is in response to both of these shifting targets. Again, not news to any of the audience, but risk of overdose and other harms due to the increasing toxic drug supply, as well as risk of acquisition and transmission of COVID-19, and risks of withdrawal for those who self-isolate or quarantine for COVID-19 reasons are all greatly increased in the context of the pandemic, and are all these conflicting priorities that we're attempting to deal with as physicians or as clinicians or other healthcare professionals who work with people who use substances. Extraordinary measures are needed to support people who use drugs and prevent ongoing spread of COVID-19. And this is what led to the development of the original risk mitigation document that was released now nearly 2 years ago in March 2020. We have, in the past 2 years, I think, accrued a significant amount of clinical experience in the prescribing of hydromorphone and MS-LON, as well as some early research, which is now starting to come out to help inform our practices in this area. I think that many of myself and many of my fellow prescribers have certainly noted that some patients do benefit from oral hydromorphone as well as prescribed MS-LON in terms of improving their ability to self-isolate or quarantine related to COVID-19, and also reduce the dependence on the illicit and increasingly toxic drug supply. But I think it's also pretty clear that oral hydromorphone and MS-LON have been insufficient for some or many patients in terms of completely severing their dependence on a toxic drug supply. Certainly, that is one of the main issues that has been raised with our current approach. In addition, while there's definitely many stories of people who benefited from these medications, there's certainly many anecdotes of diversion of these substances, of urine drug screens that are negative for prescribed substances and those who've been prescribed. So this is still an ongoing balance that we're trying to strike. I think that oral hydromorphone, in particular, where we've noted that it's being a very helpful adjunct in supporting patients who are initiating opioid agonist treatment or opioid agonist therapy, and that the use of hydromorphone has been particularly helpful in that context in helping people initiate and up-titrate their opioid agonist therapy. But overall, the incentive towards this update was really filling in some of these gaps that we've become to learn to appreciate more around who and when and why to prescribe these medications, and helping to provide more guidance on how to integrate this into either primary care or addictions practice, and how to provide continuing care and reassessment following the initiation, as well as some more refined details on again who and when and why we can to use these medications. So that's sort of the background to these documents that we're going to be discussing today. As far as the opioid use disorder, we're going to touch much less on stimulant use disorder because it is mentioned in the risk mitigation outline that we're talking about, but you should all know that a similar piece to this opioid use disorder update should be coming out imminently. That again kind of situates our experience with stimulant use or with psychostimulant prescribing more firmly in the context of COVID-19, and describes some of the more contemporary evidence and clinical experience with these medications. So stay tuned for more information around stimulant use disorder, but we will talk about it briefly today. I think that the experience of prescribers has generally been that some people actually have benefited significantly from prescribed psychostimulants, but many have not benefited much or at all from these medications. And Guy, I don't know if you want to take this slide.
Hey, sure. from my own experience as a person who uses or used to use drugs, and from the people that I do work with who still use substances, hydromorphone and MS-LON have helped many people. Obviously, I think with the combination with OAT and then having the MS-LON or the dilaudid afterwards has been really effective in reducing the withdrawal and the cravings. However, at still, with these new substances that are added, as well as, I don't look at it as a model that removes people completely, depending on where they're at. Obviously, what it does do is it reduces the risks that are involved for people, which is definitely, saving a lot of lives.
And certainly the logistical details have become many logistical challenges in accessing these medications, particularly in some areas of province more than others. And hopefully that's something that we can discuss in the discussion today. So all of this is obviously laid on top of a changing landscape in terms of current terms of the current drug supply, which has become increasingly toxic since the arrival of COVID-19. Again, many of you are unfortunately aware that the most recent coroner's report from October of last year, 201 individuals in our province died in 30 days due to the illicit drug supply. So just more death than ever before. And in the first 10 months of 2021, 1,782 individuals lost their lives due to drug poisoning. So unfortunately, we're continuing to fall behind, and that's only accelerated since the arrival of COVID-19. You're all well aware that there's increasing adulteration of the street opioid supply with benzodiazepines and benzodiazepine analogs and other psychoactive agents. We're seeing more and more atizolam, other benzodiazepine analogs, and now other compounds like xylazine starting to show up. So clearly, our current approach is insufficient, and creative and novel approaches are needed to reduce overdose and other harms. So we're going to break the discussion of the risk mitigation update into two parts. The first being a little bit of an overview here of some of the provincial evaluation, what we know so far, and then the second being a review of the actual content itself, which we'll go through relatively quickly. One, because we don't have the time to do it in detail today, and two, because a lot of it is sort of iterative compared to the previous update, and just sort of filling in some areas that we've learned to appreciate over the past 2 years. So as far as the evaluation goes, there is an ongoing evaluation. I guess that's sort of the take-home message here. So this is being led by investigations from the BC CDC, from St. Simon Fraser University, as well as from CSIR, and it's quite a large, elaborate mixed methods assessment of the impact of risk mitigation guidance on overdose, on COVID-19 transmission, and on other outcomes. So a really impressive project using a participatory approach to develop and implement the evaluation, and really looking at a wide variety of outcomes. Unfortunately, not a lot of there's no published data yet from this evaluation, but we're starting to see little bits of information come forward that are at least helping inform our approach somewhat. Some of the preliminary results that we have seen. So just in terms of pure numbers, who has actually been receiving these prescriptions. So between March of 2020, when this was first launched, and February of last year, so this is just the first year of data that we have from risk mitigation, about 6,500 people were dispensed some kind of prescription. Just under 2/3 of that, so 3,771 persons, it was the prescription for opioids. Just short of 20% was prescription for stimulants. So 1,220 patients, and the rest was made up of alcohol withdrawal medications or benzodiazepines, which are classified as risk mitigation medications underneath that framework. Although I think a lot of our conversation does focus on the opioids and stimulant pieces. So of all of the dispensations that have occurred over that first year period, 70% of those were for opioids, 20% were for stimulants, and the last 10% were these assorted other medications. So certainly a majority of the attention is going towards opioids and and hydromorphone and MS-LON. Of those dispensed in that first year, we do have a little bit of data now talking about at least mortality amongst patients who receive these medications. So of those dispensed those medications in that first year, there's 82 deaths. Of those 82 deaths, 33 of them, so 40% were prescribed opioids only, 11% or 9 of them were prescribed stimulants and opioids together. 7% or another 6 were prescribed alcohol withdrawal medications, and another unspecified medications. Another 17 were prescribed withdrawal medications only, and 17 or 21% were prescribed benzodiazepines only. So again, 40% were prescribed opioids only, and another 10% or 11% were stimulants and opioids. So still certainly a focus on opioids. Again, of those 82 people who died, we do have some data, preliminary data on the cause of death. So of the 82, only 7 actually had an active script that was dispensed on the day that they died. So the vast majority of them didn't have an active script on the day they died in that first year. For nearly half of them, the cause of death was not specified, but for the 50% where we did have a specified cause of death, none of those were actually due to illicit drug toxicity death. So again, in the first year of prescribing, of those who received a prescription, 80 of them died. The 45 of those that we have data on, none of them died due to illicit drug toxicity. Among those that did not have an active dispensation on at the day that they died, the average length in days between the end of the prescription date and their death was 41 days for opioids, 41 for stimulants, 55 for opioids, and 86 for benzodiazepines. So for those who didn't have an active script, for most of them, their script had ended some time before the actual death occurred. So this, if we were to look at these numbers then in terms of mortality rates per 1,000 person years, particularly want to focus on, again, the opioids here, because I think that was where a lot of this prescribing happens. So that's 11 deaths per 1,000 years on those who are receiving scripts. Now, it's hard to know what to make of that number because we don't have anything to compare it to, other than if you do look at overall at other populations of people who use drugs that we have data on for the last 20 years, this is certainly on the lower end of mortality rates. So if you look at other populations between 2000 and 2020, roughly, the usual numbers that we're seeing is a mortality rate of closer to 20 per 1,000 person years, and that includes data from a pre-fentanyl era. So again, really early data, not a clear comparison that can be made here, but certainly doesn't show increased rates of deaths dramatically amongst the population receiving those medications. We're not seeing them dying of overdoses. We're not seeing the mortality rate significantly higher than what would be expected. So something that maybe I hope a little bit reassuring. Again, just going through these preliminary results, almost 95% of prescriptions were daily dispensed. The vast majority of the prescriptions were daily dispensed. As far as the interaction between prescribed opioids and OAT, 68% of patients who were receiving opioids did receive opioid agonist therapy in the prior 30 days before they received their or in the prior 30 days or up to the day when they received their script for a safer supply. And among those not prescribed opioid agonist therapy in the 30 days prior, almost 2% of those received OAT with the first risk mitigation dispensation, 15% received OAT within 7 days, about 15% were not dispensed any form of opioid agonist therapy in the 30 days following the risk mitigation dispensation. So the vast majority of people who are getting this safe supply either were on OAT prior to accessing it or accessed OAT with or shortly after accessing it. So only a small number are actually accessing the safe supply prescriptions in isolation without accompanying opioid agonist therapy. So that is the bulk of the early data that I can share with you right now. I think that, not to editorialize too much, but I think from my perspective, it does tell us it's hard to to know how to compare that, because we don't have that denominator. But what we can take from this, I think, is that at least in that early data, we're not seeing evidence of widely increased risk among anyone who's receiving these prescriptions. Another data point that wasn't included there was just in the coroner, in the coroner's data from the last from that year, looking at rates of hydromorphone detected in overdose deaths. They were unchanged since prior to the pandemic prescribing, risk mitigation prescribing. So we're not seeing increased detection of hydromorphone in toxicology reports and overdose deaths either. So certainly doesn't even begin to address a lot of prescribers' concerns about the implications of diversion and what kind of effects that may be having. But I think is at least slightly reassuring that that people aren't overdosing and dying on hydromorphone. It doesn't seem to be contributing to overdose deaths. I see a couple questions in the chat here. I'll just stop and because I think this is really an important thing to be talking about. So Nick Baldwin is asking, is the research group not monitoring a comparison cohort that's receiving standard of care, i.e. OAT, but not safer alternatives, to compare those who are receiving safer supply? And so that's really the key, Nick, is what is our comparison group here? Because it's hard to know what to do with these numbers in isolation. And so these numbers here are not really are really preliminary numbers taken from some coroner's data and some of their early numbers. It's not part of their actual detailed evaluation, which does include, as best as it can, I understand it includes propensity score matching and kind of as much of a comparison as you can make to other groups in the current era, because a lot of these numbers here are also, we're comparing it to data that have been taken over the last 20 years rather than just the fentanyl era. So we don't have much of a comparison to make right now with these numbers, but I eagerly await sort of some more refined analysis that's coming from this collaborative, which has not been published yet, but I understand it should be coming out imminently, and I hope it'll be really informative and give us a lot more comparison than what we're seeing here. Tommy Brothers here has included I think this is a preprint, I believe, of his applying these guidelines for pandemic prescribing to groups isolating in hotel shelters in Halifax, Nova Scotia. So for any of you guys who are interested, they have some content there on their experience with this guidance in their context. And yes, so Connie Carter here has outlined there is a pretty detailed proposal of what the evaluators are planning that was published. I think it was 2021, and the link here is in the chat. So for those who are interested in what exactly they're planning, it's being pretty carefully detailed. We're just awaiting actual data now, and I'm quite hopeful that that'll help answer a lot of these questions better than the data that is presented. But like I said, if there's one thing that I do take away from that data is that and this is only the slightest comfort, but people aren't dying of hydromorphone overdoses, and those who are accessing those scripts don't have overwhelmingly increased overdose death rates compared to what we might expect. So hopefully we'll know a lot more soon. If there's no other questions, so I'll dive into a little bit of the update overview now. So just to be clear, for the context here, this is undertaken at the request of the Ministry of Health and the Ministry of Mental Health and Addictions, as well as from prescribers who are looking for more guidance and more details, because the original risk mitigation document was put together quite rapidly based on the overlapping public health crises that we're experiencing, and such a thing had never been done before. So we were really so this update does include some of the lessons that I've learned. It's been updated in response to feedback from prescribers who are seeking additional clarity and guidance. Wide consultation was involved in that, including OAT prescribers, health system partners, as well as people who have lived and living experience. To be clear, this particular section that we're talking about, the risk mitigation update, really is specific to the context of COVID-19, self-isolation, utilization in isolation shelters or COVID hotels or elsewhere. The broader discussion on safer supply, we kind of get into that a little bit in the OUD update, and will be an ongoing discussion. That's sort of the background on this piece. So the updated clinical guidance does include a further detail in a number of areas. So a little bit on patient planning following the initial medication trial and on assessment. We talk a little bit more about the limitations and uses of urine drug testing in the context of risk mitigation prescribing. A little more detail they're provided on obtaining informed consent from people who are accessing these medications that don't have a broad evidence base to pull off of. Further guidance on missed doses for opioids and stimulants, and management of benzodiazepine withdrawal, which is unfortunately becoming an increasing issue, as you're all well aware. The role of peer navigators and advocates, rural and remote considerations, billing, and some clinical scenarios to hopefully provide some clinical cases to illustrate how these guidelines can be applied. The eligibility remains the same. So individuals who require support to physically distance, self-isolate, or quarantine in order to prevent the spread of COVID-19 and ongoing active substance use, so accompanied by a high risk of withdrawal, overdose, craving, or other harms related to substance use. So the eligibility themselves hasn't changed much from the previous update. For special populations, for youth, for pregnant people, certainly they're not necessarily, they're not exempt from this guidance by any means, but it's certainly additional expertise is often required in managing some of these special populations. And so if you don't have that expertise, then resources such as the Race Line, your local addiction medicine specialist, or the 24/7, the BCCSU 24/7 consult line are all available to help talk through some of these more complex cases. In particular for pregnant patients, perinatal addiction specialists or the 24/7 line are really valuable resources. Because those often become quite complex. So again, I'm just going to go through some of this quite quickly because it is all outlined in the document. But we talked a little bit about eligibility being one of the areas that we've kind of further fleshed out in this document. So including assessments, the assessments that should be done up front with patients before engaging in risk mitigation prescribing. So certainly an active substance use assessment and substance use treatment history is really important. Collecting information on past consequences of substance use, such as overdose, comorbid mental and physical conditions, especially those that might affect the safe prescribing these medications, other prescribed medications, current access to a prescriber, as well as requirements for support in physical distancing, both in terms of physical requirements as well as what is needed to help manage their substance use during self-isolation or quarantine. As far as medications, the actual medications included have not changed. So the medications that are eligible for pharmacare coverage in the province of BC include hydromorphone and MS-LON, as well as methylphenidate, dextroamphetamine, and benzodiazepines, specifically clonazepam, lorazepam, and diazepam. As you're all aware, non-prescribed substances are also addressed in the document, including alcohol, tobacco, and cannabis. These are not covered by pharmacare, and depending on your local area, some health authorities have established systems to access some of these other medications or other substances for people who are undergoing quarantine. So other alternative pharmaceuticals that are not listed under risk mitigation may be available, and this is speaking primarily these days to the fentanyl patch, as many of you are familiar with the provincial pharmaceutical alternatives policy. Fentanyl patch specifically is available in a few settings through health authority associated programs. It's not a part of these risk mitigation guidance, but if you are looking for access to some of these alternative pharmaceuticals for your patients and you're not sure where to find them, please speak to your local addiction specialist or to the addiction lead in your health authority. Similarly, we have not changed guidance on dosing or titration for these medications. This has remained the same. So as you're all well aware, about 95% of the prescribing that is being done is with oral hydromorphone tablets, the 8 milligram tablets. Typically 1 to 3 tablets QOH has been, I think, the most common dosing regimen that's used, up to 14 tablets per day, generally dispensed daily and non-witnessed. And or MS-LON, only about 5% of the opioid prescribing has been MS-LON, and similarly, the dosing range has not changed there. As far as stimulants go, not a lot of change here other than just, again, filling out kind of the difference between some of the sustained release and immediate release formulations. So we are still recommending primarily dextroamphetamine or methylphenidate as the two stimulants that have the most evidence in the literature around at least kind of safety and prescribing patterns. So dextroamphetamine, either sustained release or immediate release. A couple examples of dosing regimens that are provided here, but really the total daily dose of 80 milligrams of dextroamphetamine per day is probably the most important number to keep in mind. That is the highest dose at which there is reasonable safety data for in the literature. So that's being the upper limit outlined in the guidelines, although certainly there are examples of people going higher than that. I think if you do exceed that, it's really important to have careful conversations with your patients and really clearly document that, because there's a real lack of any kind of safety data above 80 milligrams of dextroamphetamine. And similarly with methylphenidate, many people, and at least in my clinical experience, find a benefit in combinations of sustained release as well as immediate release medications. I often get questions, especially on the race line, about how to come to these decisions on how to dose these medications. I think really it is a collaborative thing. I generally ask patients and make my own suggestions based on what other people have told me works for them. But I think it's really collaborative decision making and making adjustments together based on what their experience is like.
Paxton, there's a question from Melissa Allen who says,
I see that, yeah.
Can you comment on the use of these
Sure.
guidelines for prescribing these medication for people who are not self-isolating or not in quarantine? Will the prescriber then not be supported if reviewed or audited by their college?
So it's a good question, Melissa. And to be clear, so what we're talking about right here is specific to the context of COVID-19, because there was a clear ask from some prescribers for guidance that's very specific to that context. The OUD update, which we'll be talking to you in the later half of today, is speaking more generally to the prescription of hydromorphone and MS-LON, not for the purposes of self-isolation, but for more kind of the broader goals of quote unquote safer supply. So from reducing people's dependence on the toxic drug supply and overdose reduction, and hopefully improve quality of life. So that guidance is included more in the OUD update. The specific numbers and dosing strategies, that they're really similar between the two of them. Technically speaking, I guess you'd be using that guidance in the context that you're describing. The college is aware, like at least our college, the College of Physicians, is very aware of that and has seen and offered their own input to this guidance, and are, I don't want to put words in their mouth, but as long as you're adhering to this guidance, are aware that people are doing that and are I wouldn't go so far as to say in support of this, but are understanding of the rationale and what's going on, and you should not be no one should be audited or reprimanded if you're prescribing within the framework that's outlined here, and that's been pretty clearly established and agreed on. For anyone who is having I should say that the college is reaching out to people to inquire about the prescribing practices, to make sure that or to try and best as they can to make sure that they're being that they are adhering to this guidance, which is not, at least from their perspective, it's not an audit. It's more of an inquiry. I don't know, it's a bit of a gray line there, but if people are experiencing are being audited or are feeling that they're being unfairly targeted for prescribing within the guidance outlined here, please reach out to me or to the BCCSU or me directly, because that really should not be the case. And I'd be very eager to find out more about exactly what's happening, and be more than happy to do whatever I can to help people through that process, because these times are stressful enough as it is. So I hope that sort of answers your question in a roundabout way. Just back to these okay. So I see another question here, which I'm gonna take a second to address because I think it's probably on everybody's mind, especially when we're talking about benzodiazepines these days. The question is just confirming this benzodiazepine taper is okay for individuals who have dual dependencies from opiates tainted with benzos. We have a lot of concerned community members with the dual dependency and no resolution for the benzos. So this is sort of the elephant in the room these days. It's not even an elephant, we're talking about it everywhere. But how do we deal with the increasing contamination in the opioid supply with benzodiazepines, with non-diagnosed or undiagnosed benzodiazepine dependency, with risk of benzo withdrawal, with all of this inadvertent exposure that we're seeing? And truthfully, I have no easy answer for you. It's extremely challenging. The most common thing that I suggest is that people do call the race line or the 24/7 line when they do end up in that situation. But it's something that there's no clear, there's certainly no clear way forward in those situations. They all have to be kind of addressed individually. It's really tricky, and it's only getting worse. It's something that the BCCSU is very aware of, and we're trying to release whatever tools or advice that we can as quickly as possible to help provide guidance in that area. But truthfully, none of us really know what we're doing. And so I think the most helpful thing that prescribers can do in that situation is call 24/7 or call RACE to at least have a conversation around it, or speak to other your colleagues, because I think that in general, prescribing or initiation of benzodiazepines in the context of people with opioid use is not a particularly good idea. And we know it increases the risk of opioid use. We know you can develop an iatrogenic benzodiazepine dependency, which you wouldn't want to inflict on anybody. But the risk of benzo withdrawal is real, and we're seeing seizures in places like Vancouver Detox from that. So hugely challenging situation. And I think the only thing that I can say is that the approach has to be individualized every time right now. It's the bane of my existence. For the purposes of this document, we're really being a bit more specific with benzodiazepines, talking about benzodiazepine maintenance for those with benzo use disorder in short amounts of time during the isolation itself, and encouraging benzodiazepine tapers for those with benzo use disorder in the longer run, which is no different from guidance we would have provided prior to COVID-19. As far as alcohol use goes, really no change here. Again, reference to the PAUSE score as a tool for risk stratification, the variety of medications are available either for withdrawal management or in some situations where managed alcohol is available. That's being implemented really successfully to help with self-isolation. Similarly, no changes in the guidance around tobacco here, other than providing people with nicotine replacement therapy as needed, and for those who have an interest, taking advantage of prescription-based pharmacotherapies for cessation, including varenicline or NRT. And lastly, for cannabis, same thing. So some health authorities in some settings have established systems for access to cannabis or either combustible cannabis or edibles to be used for the purposes of self-isolation, and general counseling around cannabis use, low-risk cannabis use for patients who are consuming this. So this is one of the, I think, probably major updates included here is once you've initiated these medications, then what? How do we proceed once you've opted with a patient to start them on hydromorphone or dexedrine or whatever? So within the 10-day isolation period for COVID-19, that's a relatively short timeline. That's one thing. But what happens once COVID-19, once they're out of isolation, and their risk of overdose remains high. So as many of you will experienced, many of our patients who we've provided these medications for, specifically for the purposes of isolation, have had ancillary benefits. They've found less of a dependency on the the illicit opioid supply. They find that it's helpful in severing their dependence on an increasingly toxic supply. And so this update does outline specifically that if prescribing demonstrates a benefit to a patient, it should not be discontinued solely due to reduced COVID-19 risk. That is not a reason to cut them off, as people are saying. But again, going back to the question that Melissa had earlier, no guidance provided here on initiating medications outside of the context of the COVID-19 pandemic. I'm seeing a few other comments here. So yeah, there's a comment here that the coroner's report released last February clearly demonstrated it wasn't not prescription benzos found in overdose patients. 100%. This is almost exclusively driven by increasing penetration of benzodiazepines and benzo analogs into the toxic drug supply. That being said, I think you have to really initiating benzodiazepines in patients who are on opioid agonist therapy has major drawbacks that need to be considered. Conventionally, it's obviously something we would not recommend. Currently, I think you really need to evaluate the risks and benefits on a case-by-case basis. Carolyn Ferris is asking, what does authorizing cannabis mean nowadays post-legalization? Does a prescriber really need to be involved? Also, great question. Considering that the program stipulates they have to order from licensed producers anyway. So why don't they just order for a dispensary with delivery if they have to isolate? That would be a totally reasonable approach if somebody could afford that. If I look at like our isolation establishments in Vancouver, we have means of getting access to cannabis where they don't have to pay for it themselves, and that's what authorizing means, at least in my context, where we could provide it to them on site for the purposes of self-isolation. But certainly encouraging them to have it delivered. I think if somebody had the means to do so, I think is totally reasonable as well. So this is I'm going to keep fielding these questions as we go, because I think it's just this is what we're all here for. Susan Nooch, is there any effort to measure potential increased harms resulting from hydromorphone diversion, such as increasing number of new users, and how much is being diverted? And I think this is really such a hugely important question for those of us who are actually prescribing these medications, and it is something that's on all of our mind. It's a really, I would defer to the evaluators, because I am not a part of that group, as to specifically how they plan on addressing that question. But it's just such a hard question for me to wrap my head around from a research perspective, is how you'd even begin to quantify that, at least in the short term. 5 or 10 years from now, we'll have a much better sense of it, but that's not particularly useful for us in this moment. But I think that's the question on everyone's mind, is we've all seen, I shouldn't say we've all, I've certainly seen increased benefit for these medications in some people, but we're only seeing one half of the coin. And what are the potential harms that are out there, and how are we evaluating those? How are we quantifying that? It's a really challenging thing to do.
I also think that when you look at addiction, and if somebody is already in addiction, it already actually exists before they've hit the healthcare system. So a lot of the times too, I don't believe that these drugs would create new addictions. I'll tell you this, if somebody wants to purchase substances, they don't go purchase Dilaudid. And if they did, it would at least not kill them. So there's those risks and the benefits on both sides of it. And if you look at, a lot of the youth that are in our world today that have died as well, they've died from fentanyl, not purchasing Dilaudid. And then if you look at the leading cause of death in the province of British Columbia for anyone between the 19 to 39 range of age, that's the leading cause of death, illicit opioid toxicity. So we have to do a better job at trying to remove people from that supply.
Thanks, Scott. Thanks for your perspective there. I think we could have an hour and a half discussion on that question alone. But I'll leave it at that for now. Other than I too have that I'm curious about that question, and I don't know. It's a deceptively challenging one to wrap your head around.
Yeah, and even, sorry, just one more thing, Pax. Even what
go ahead,
a lot of the times too, the truth is that me as a substance user, what the medical system may cause may call diversion, we call it, helping each other out. I mean, if you see somebody that can't access something and they're in severe withdrawal, then, that's what a lot of friends do, especially in a tight-knit community, especially with substance users who have been, discriminated against and stigmatized against and criminalized against for decades. This is the devices that the policies in place have left us with, is that we just really have to help each other. And yes, it may be a little bit of what you may call diversion, but really the reality is that we're just trying to help each other. And if we can help each other so that we're giving somebody a known dose of something that's not going to kill them because they're our friends, then that's what people will do. It's not so much that it's a bad thing. Really, it's the policies that created it.
I think that's a really important perspective, Guy. I mean, I think that's like you said, it's what any of us would do. And how do we balance, like, how do we actually ever wrap our heads around all of the implications of diversion, or what we're calling diversion? There's a comment here saying the college has said if still fentanyl in the urine drug screen, no way to know it's helping, seem to suggest not be continuing to use. I mean, I think that the presence of fentanyl in somebody's urine drug screen as a binary thing is a very crude way to assess whether this is helping. I think, that's the question you're asking there is our current safer supply framework helping people to abstain completely from a toxic drug supply? And I think that's I think everyone here would agree that's not what we're seeing most of the time, and it's probably an unrealistic goal, at least with the current system. But that by no means, I can see do not agree with the college. That's a very crude assessment of whether somebody's benefiting from the prescription. Much like if they're on methadone, no one would say that people are not benefiting from methadone if their urine is still positive for fentanyl. I think you lose all of the nuance. Another question here about people's Dilaudid prescriptions being cut in half in the community, and I don't know anything about that. And if that is something that is actually occurring, please let us know about it, because I'm not sure where Carly Fennell's calling in from. But is back to the last couple of slides here around the risk mitigation update, because again, I think this is one of the major pieces that's being added to this document is actually how to assess for benefit continued prescribing. So this kind of speaks to the last comment here. So clinical indications that a patient might be benefiting from safe supply are, I think, go way beyond whether or not they still have the presence of fentanyl in their urine. So just reduced cessation of illicit substance use alone, or even less risky use, people not like rushing a shot in an alley, but using it in a more kind of controlled way. That itself is I think a sign of a benefit from these prescriptions. Further to that, reduce incidence of overdose or emergency room visits secondary to the prescribing, reduce cravings or improvements in their ability to self-isolate quarantine. As I said, reduce emergency visits or admissions to hospital, reduce exposure to infectious diseases due to either reduced use or just safer, more thought out use. Increase engagement in primary care and other health services is, I think, a really important and underestimated potential benefit. Improve functional outcomes, manage withdrawal symptoms, overall reports of improved well-being. These are all markers of benefit from continued prescribing that go well beyond just a positive urine drug screen, which is listed here in the bottom, but is by no means the only means of assessing for benefit. Part of the reason that, and I hope that this goes back to, again, that comment around the college and the college's views, and this is part of the reason that that we fleshed out a lot of these pieces in this document is that, I hope these are the kind of conversations we're all having with patients when we have them on medications, to actually feel out what kind of benefit this is providing in their life. But the assessment and documentation of this kind of thing is exactly what the college wants to see in prescribing these medications. It's just that we're being thoughtful about it, and that we're not just writing scripts and throwing them out the door, but that prescribers are talking to patients, establishing mutual goals, checking in on those goals, and are incorporating this into good addiction care, good primary care, rather than just prescribing and not asking questions. And I think that's that if you're prescribing through that lens, and these are the kind of things you're considering, it would be very hard for the college to have any issue, to take any issue at all with one's prescribing. So this is an example, one of the case studies. So there's a number of cases that are included in the document, but an example of somebody with concurrent opioid and benzodiazepine use. So Sandra, a 42-year-old female with mild upper respiratory tract infection symptoms, uses opioids and benzodiazepines daily when she can get them, and is asking what she can do to keep herself safe. So her assessment, she's stably housed. She's using a quarter per day, and using Xanax on top of that. Has previously been on methadone, but has found the side effects to be quite intolerable, and has no history of complicated withdrawal from benzodiazepines, but certainly feels that she'll need them to be able to help self-isolate. Not currently interested in opiate agonist therapy. So an example of a treatment plan for her. So she may be at risk of COVID-19. She does have those URTI symptoms. So she should be self-isolating at home, away from other people. Remind her to call 911 if she does have trouble breathing, and encouraging her to get tested for COVID-19 and providing information on those testing sites. As far as prescription to assist her in self-isolation in the interim. So certainly offering a methadone or Cadian restart, which she's clearly stated she's not interested in today. So initiating her on MS-Lon as well as hydromorphone tabs, delivered, daily dispense, not witness dosing, and just discussing with her ability to stay stable while being prescribed these medications, especially while she's alone. That gets at that informed consent discussion that should be had with anyone who you're engaging in safer supply prescribing with. As far as the benzodiazepines go, so particularly if she's confirmed COVID-19, she's going to be self-isolating for, it's now 10 days, not 2 weeks, but a taper for benzodiazepines can certainly be offered if she wants to stabilize and taper off of a benzodiazepine use. If she's not interested in that, then providing her with something to help her achieve that goal of self-isolation for her 10 days. Clonazepam 1 mg PO BID daily delivered along with her OAT would be a reasonable starting place, along with frequent reassessments for benzodiazepine withdrawal and adjusting the dose for signs or symptoms of benzo withdrawal. So if she does end up being COVID-19 negative, or once she clears her quarantine, then certainly a taper could be initiated with her if she's interested in engaging in that. So that is a very quick overview of the risk mitigation updates. So again, the big updates there primarily being things like what to do, some more details around assessments before starting somebody on treatment, a little bit more refined guidance on dosing, and especially what to do once somebody's been started, and guidance and kind of ongoing care there. That sort of transitions into the OUD practice update. Before I get there, I want to see whether Guy, you had anything else you wanted to mention just related to this document?
Just that I would hope that as prescribers, we would look at reducing the risks and the harms caused by the illicit drug supply and manage that into your practice of prescribing. It's oftentimes like us as substance users, when we walk into your facility, it's not just you and me, it's you, me, and every bad experience I've had through the healthcare system. And I often think of the times that I was just turned away or called drug seeking when I was really just asking for help, but nobody was giving me any options. And a lot of the times the options that we're giving weren't working. And so I think if you can't do it, then I think in due diligence of a prescriber is to send somebody to another facility that will do something instead of just telling them to leave the facility. I think that's very important because it's alarming how long this is continuing to go on for. And now that we're moving away from COVID, the amount of people dying is just egregious.
Yeah, I mean, it's unspeakable. This is a very hard world to be working in right now. And again, just thank you guys all for taking the time to call into this and for the work that everyone does. for your interest in these documents and this type of prescribing. Any questions from the audience around this particular one? We'll have, again, hopefully have discussion time at the end, but I'm trying my best to field those as we go along. But if not, here's one. This is an interesting question. So one thing mentioned is that the discrepancy between what we're prescribing and what people feel they need is one of the major concerns of the prior risk mitigation guidelines. Given the potency of the street supply is exceptionally high and it's only climbing, has there been discussion around increasing or altering the guidance to address the massive opiate burden of the street supply, considering that our current numbers are clearly inadequate? Lots of discussion, I suppose. So we haven't made any considerable change because again, this was much of meant to be quite an interim update while we're waiting for more data around the actual evaluation itself, and which is taking unfortunately some time. But again, I hope it's coming soon. I think that's a really critical question. Is reassessing not just the amounts prescribed here, but also the nature of the opioids we're prescribing and whether they're actually achieving those goals. That's another discussion all of its own, and something that I think about a lot. But for the interim, we haven't gone down that pathway of actually changing the medications themselves. Other than that, this guidance does provide that limit of 14 tablets, but there is room to go above that, and it is outlined there as long as there's a clear documentation of kind of why that's being done, and as long as that can be it's recognized as somewhat exceptional, and there's a clear rationale and a clear discussion documented. So there's some room for prescriber discretion there, but we're waiting for more results from the evaluation, as well as a broader rollout of some of these other pharmaceutical alternatives program before we actually go about making significant changes to any of this guidance. Another question here, wondering what the current strategy is for patients who are getting back a urine drug screen that's negative for hydromorphone in patients who are currently prescribed hydromorphone. We've had situations where there seems to be benefits in terms of increased connection with the health system, in connection with social supports, use of ARVs, etc., as well as, if there are other positive outcomes but a confirmed negative urine drug screen, increasing the concern for diversion, is this a hard line through the college to discontinue prescribing unwitnessed opioids, or would be supported to continue based on the individual case if it's supporting other positive outcomes? So this is mentioned. This is a great question, and I think one that comes up a lot, and it is mentioned in this opioid use disorder practice update, although albeit in a footnote there. So my answer for you would be no. I think that much like with methadone or buprenorphine, that reflexive actions based on a single urine drug screen is not good care, and that we're all capable of being better than that, and of actually addressing individual situations. Many of our patients might not take this drug, their hydromorphone. They may not pick it up every day, or truthfully, they may tell you that some days they take it all at once in the morning, and other days they stockpile it. I think that a negative urine drug screen for a medication you're prescribed should probably prompt a conversation as to how they're taking it, when they took it last, like what's going on. And if you're having consistently negative urine drug screens for hydromorphone, then certainly you need to, that should prompt some further questions. But what I would strongly advocate against is reflexive action, just based on the results of a urine drug screen, which is a test of marginal clinical utility at the best of times. So I think that again, documented conversations with patients and how they're using their medications and when, and documentation of the reasons you're continuing, and those all the benefits you are seeing are all really important. But I would not ever advocate for somebody to be cut off from a prescribed medication based on a single urine drug screen, which all it'll tell you is they haven't taken any hydromorphone within the past 12 hours in this one time. But that is spoken to in this OUD practice update. And maybe with that, I'll get into the other half of the presentation. So this is where Ruby was going to be talking, but I'm happy to fill in for her. This is somewhat of a twin document to the risk mitigation one, which as I mentioned is really meant to be used in the context of COVID-19 and was in response to very specific requests from prescribers to have a tool that they could use for isolation in COVID-19 with clear parameters drawn around it. This OUD practice update speaks to some of the broader questions that have already come up in the conversation. And I'll say that it's divided into two sections. So there's sort of two. The background to this particular piece is that you're all aware that the guideline for the clinical management of OUD was first published in 2017 by the BCCSU, which was a pretty comprehensive guideline assessing the evidence and best practices of care for the treatment of OUD at that time. A comment here about the college stating hydromorphine is being sold to teenagers in schools and suggests that's a big problem. I suspect this is hyperbole. I also suspect it's hyperbole, Brian. Although, again, it comes down to, again, there's anecdotes on both sides of benefits and of harms from safe supply, and then you can even take the anecdote of hydromorphine being sold to a teenager in school, and an advocate would say that's great, at least we're using something predictable, whereas obviously somebody who's more of a critic would suggest we're developing a new more patients with an opioid use disorder, and we're actually generating more opioid use disorder based on this prescribing. So the exact same story can be viewed through two different lenses, unfortunately. So this is why the broader evaluation is so desperately needed. Not to get off track here is that the initial guidance came out in 2017, but clearly lots has changed since 2017. Not only in terms of what we know of the treatment of opioid use disorder and the tools available to us, but also in terms of the context and what we're working in around the increasing poisoning of the drug supply. So that's what led to the OUD practice update, which is next slide, Lisa. So it's divided into two parts. The first is a more traditional practice update, providing guidance around changes in practice in the treatment of opioid use disorder over the past 5 years. Many of you may be aware that we do have a committee and have been intending on updating those 2017 guidelines in a really thorough and fulsome way for some time, but unfortunately, all of the responses to COVID-19 have delayed that. So I do hope that we see a formal updated guideline by the end of 2022 or early 2023 at the latest. In the interim, this practice update was meant to fill in some of those gaps around some of those the new practices in opioid use disorder treatment, both for educational purposes as well as to make sure that people are confident that their practice is supported by guidance. The latter half of this practice update is, as I mentioned, it's taking the clinical experience we've gained from risk mitigation prescribing that does show some patients benefiting from hydromorphone and MS-LON, and providing further guidance on who and when and how to trial this intervention outside of the specific context of COVID-19. So as far as opioid agonist therapy update, it's included in the practice update is certainly, I would say, our clinical, well published literature has yet to catch up and show the implications of fentanyl in the drug supply on retention into treatment with opioid use disorder, or on retention with opioid agonist therapy, and on the kind of doses that are needed. That's remains not well described in literature, but anyone who's been practicing in this field for the last few years in BC, I sure can attest to the fact that higher doses of OAT are certainly needed in some, if not many, contexts. Buprenorphine naloxone is still it's still outlined as a quote unquote first line medication in this update as per the original guidelines. But I really want to stress that this is not a traditional first line, second line, third line that we see elsewhere in medicine, where you must trial one before moving on to the next, is that all three medications should be available for treatment for anyone. That's buprenorphine or methadone or slow release oral morphine. Clinical judgment and working with patients can be used to select the most appropriate medications to try. Certainly, I still really am fond of buprenorphine naloxone, and in the right patient, it will certainly be my first line option because I know that it provides the most flexibility, but by no means is it something that that people must try before progressing into other forms of OAT. I'm sure everyone here has heard of or is aware of microdosing induction for buprenorphine, which was, I think, a really helpful tool when it was when we first started exploring it in about 2017, 2018. And in the context of fentanyl increasingly challenging, buprenorphine inductions has become that much more common in terms of an induction technique for buprenorphine, but it's not described in any guidelines anywhere, and still minimal evidence in the literature actually outlining best practices in this area. But the practice update does kind of summarize what we do know about microinductions and provides some guidance on who and when this might be a preferred induction strategy, as well as guidance on some examples of how microinduction, what a microinduction protocol might look like, although there are as many variations out there as there are prescribers. This being one of those now, I'm seeing a number of comments here around hydromorphone in Victoria. Again, Carolyn, I've seen some primary hydromorphone disorder, not a lot. I'd say it's been very infrequent in my own clinical experience. And certainly there's no problem buying it off the streets. We're well aware of that. Whether that's a net benefit or harm, I don't know that any of us can really say. And Jared Assen, sorry if I'm pronouncing your name wrong, is just describing some of the results of the drug checking project in Victoria, looking at the actual composition of the toxic drug supply and what that means in terms of morphine equivalence, which is obviously extraordinarily high, higher than we've ever seen it, and still climbing. And there's some really good data on that through the BCCSU drug checking program, outlining how that's changed in the past number of years, especially since COVID-19, since the pandemic was declared, how the potency and volatility of the drug supply has been changing. So that was just an example of what a microinduction protocol may look like. Again, I'm sure many of you are familiar with microinductions, but they're fleshed out somewhat in this practice update. A further update on buprenorphine that's included here is just an outline of other buprenorphine formulations that have become available in Canada since the 2017 publication. So in 2017, that was shortly after buprenorphine was sort of officially recognized as first line treatment for OUD in the province of BC. Since then, a number of other formulations have come on the market. Sublocade being the one that most people have probably now heard of, which is a 1 month long-acting subcutaneous injection. So an extended release formulation of buprenorphine. Probufene, another extended release formulation, much less commonly used. It's an actual implant, but it's good for 6 months at a time. More recently, the Suboxone film has also been made available in Canada, which has been available in the US for some time. So just a different formulation that is available for people who find the tablets to be particularly intolerable, although the film remains not covered by pharmacare. So a little bit more detail provided in some of these other formulations that are now available or not included in the 2017 OUD update or OUD guideline. Next slide, Lisa. As far as updates around methadone, again, many of you be aware that we have multiple options now available for methadone in the province. Methadose being remains the default as the form of methadone that was introduced in BC in 2014, but Metadol D There's another formulation of methadone that is now being widely available since 2019, as long as you indicate it on a script for patients who have a preference for Med-LD. Compounded methadone, the original methadone that was replaced in 2014, is also available again in our province now as an exceptional option, but does require special authority at this point in time. So we have 3 formulations. As of last October, the 4th formulation, the Steranova or the blue methadone, is no longer commercially available. But I think that that was one that I saw quite infrequently. So methadose, Med-LD, as well as compounded methadone are all now available, and that is described in your update. Slow release oral morphine. I think this is something that we've all learned a lot about in the last 5 years. So, as many of you may be aware, SROM was the inclusion of SROM in the 2017 guidelines was the first time in North America that this medication had ever been used for the treatment of opioid use disorder. So it was very, very new at that time. We have learned a lot just based on our clinical experience alone in the last 5 years, and I think the generally agreed upon practice pattern in the province has changed quite dramatically from what was provided in the 2017 guideline. So this is, I think, one of the really critical updates in the OUD update is just reflecting dosing strategies that are much more that are examples of what's actually being used out there today, because none of us are actually adhering to the original dosing that was provided in the 2017 guideline when we didn't really have much understanding about this medication. So as everyone here is well aware, starting doses as high as 200 milligrams are very commonly used, with titrations often about 100 milligrams every 24 to 48 hours. So that is now reflected in this update. So hopefully helps people feel a little bit more protected or supported, I should say, in what's become pretty much the standard prescribing pattern for SROM in the province in the last number of years. The highest dose of SROM that's described in the literature remains 1,200 milligrams, but certainly, especially in the context of fentanyl, and especially considering the tolerances that we're seeing these days, I think it's become extremely common for people to require doses above 1,200 milligrams. So the practice update does reflect that, and just asks that we be as we start to get to higher doses of SROM or methadone for that matter, reasons for increase are being documented, and reasons why that that we're assessing whether increases beyond at these higher doses are still thought to be are still providing benefit or not. I think that in my experience in my clinical setting, almost nobody's stabilizing at less than 1,200 milligrams. I have a question here around, so we have one question here saying a local practice at a high volume OAT clinic is starting SROM at 300 or 400 milligrams. So that's not, I would say that is something that we certainly see, and I would say at the Rapid Access Clinic at St. Paul's Hospital, we're doing a variety of rapid titrations through with research ongoing as to how we can most appropriately and safely dose medication. I would say right now, 300 or 400 milligram doses are not starting doses are not supported by the practice update. So if anyone is doing that, there's clinical judgment applies, but it's certainly outside the realm of what's included in this update. But this is an area of active research, I think, at least at St. Paul's for our group, as to how we can safely determine what are reasonable starting doses and titration schedules for this particular medication. Another question here on the highest you've seen. One comment: I have a few patients on 24 to 2,700 milligram daily doses. I would say that's sort of been my experience as well. Is I'd say in my clinical experience, very few people are stabilized in less than 1,000. Most people somewhere between 1,000 and 2,000. Pretty infrequent people are needing more than 2,000, but certainly I'm seeing a number of people on 2,400 plus hydromorphone. I've never seen anyone reach 3,000 personally. I'm not sure if anyone else on the call has, but I'd say usually the high teens is what I'm seeing in my own clinical practice these days. So this is an example of a titration schedule for SROM as reflected in the new practice update. And so that kind of brings us to the end of the first half of the practice update, which is again more traditional updates to our practice of addiction medicine in the province, and the latter half of it really is speaking to safer supply and prescribing to reduce overdose risk. So there's a dedicated section in this opioid use disorder practice update around the prescribing of hydromorphone and MS-LON as a harm reduction approach. We'll say right up front that these are not meant to constitute treatment for opioid use disorder. We would never want it to be construed that way. Certainly not evidence-based practice, but these are harm reduction approaches that we are learning more about, and certainly clinical experience shows that at least some people do benefit significantly from these medications. And again, for prescribers can consult the provincial prescribed safe supply policy as well as the local regional health authority for information on facilitating access to other forms of prescribed safer supply, such as the fentanyl patches, which are beyond the scope of this document. And as I mentioned up front, that mention of them at the very end of this document has been removed to avoid any confusion at all. So prescribing to reduce overdose risk, eligibility, ongoing active overdose use, and a high risk of drug poisoning, which is essentially anyone who's using any opioids these days. So certainly a pretty broad eligibility criteria. And the dosing strategy outlined here is exactly the same as the one in the risk mitigation document. That has not been updated at all from the original risk mitigation outline from 2020. I see a couple more questions here I'll take. So one, do you know of an opioid conversion chart showing the equivalence of methadone and morphine to heroin and fentanyl? Yes, sort of, but those are, that's a deceptively tricky question, particularly for methadone. Methadone doesn't actually convert linearly to morphine equivalence. So the conversion of methadone into morphine equivalence is somewhat hotly contested and it's a little bit tricky. But if you ever need to make that conversion and you're not familiar with it yourself, and speak with some other addiction experts around you, or feel free to call Razor 24/7. Morphine and heroin are pretty clearly defined. Fentanyl is somewhat clearly defined, a little bit more gray in terms of the actual conversion of morphine equivalents. But as Melissa's pointing out here, is that the non-prescribed fentanyl is different than prescribed fentanyl in terms of its dose conversion. I mean, on the one hand, fentanyl is fentanyl, but the drug supply is so volatile that it's really just hard to make that prediction. I think the most recent drug checking is that between 5 to 15% or of whatever it is that people are using is actually fentanyl. So a threefold variation in potency right there, not to mention the fact that there's fentanyl and various other fentanyl analogs, as well as many other additives which may potentiate the fentanyl, such as benzos, or benzodiazepine analogs, such as other non-fentanyl opioid analogs, which we're seeing emerge more and more often, and such as other sort of more exotic substances like xylazine, which are starting to show up. So it's extremely hard to make the conversion from street fentanyl because nobody knows what they're buying. And that's really the crux of the problem. Next slide, maybe, Lisa. This is just the same dosing strategy as was outlined in the previous document. As far as assessing for benefit and continued prescribing, again, this is I think an important addition here to support prescribers in continuing to prescribe this medication, as well as to kind of outline how to do that in a way that's safe and satisfying as a prescriber, and also satisfies the college. Just ensuring that, again, we're not just prescribing this and not asking questions, but it's actually part of thoughtful primary care or thoughtful addiction care. So we've gone in and detailed some suggestions around how to assess for that benefit, which again are pretty similar to those outlined in the risk mitigation update. Next one. So as you can see, just to summarize, I think it's about having conversations with the patient to assess whether they're benefiting or not from the prescribing, and if not, is it because the dosing suboptimal or because it's not the right thing for them at that time? So there's clinical indications of benefit. Are they overdosing less? Are they staying alive? Are they not ending up in the emergency room and in hospital? Psychosocial indications of benefit in terms of housing or employment or just generally quality of life. And then some indications the patient might not be benefiting are outlined there as well, such as ongoing overdoses, multiple serial urine drug screens that demonstrate they're not even taking the medication, etc. Which I think again should not necessarily prompt somebody to be quote unquote cut off, but certainly should prompt a discussion on why is this not working and what can we change. So this is just again speaking to the evaluation, which, as I mentioned, is ongoing. So this is an important change from a technical aspect. So for prescribers that are out there, is one of the challenges that the CDC has had in their evaluation is actually teasing out what prescriptions from PharmaNet have been written for safer supply versus what are being written for pain patients on hydromorphone or for other purposes. So what has been asked of us as prescribers, this is in the document, and I'll state this as clearly as I can right now, is that in order to facilitate that evaluation, in order to help identify which prescriptions are being written for safer supply and which are being written for other reasons, we've been asked to indicate that clearly on the instructions for all of our duplicates. I think most, if not everyone has been writing, for safer supply or something like that on it. That you can continue to do exactly that, and a pharmacist will be able to interpret that when they put it into PharmaNet, but really adding in the code SA for safer alternative in the instructions for use section is sufficient to cue the pharmacist to make that adjustment when they put the medication into PharmaNet, so that our evaluators can actually identify clearly what prescriptions are going where, and hopefully will help facilitate that evaluation that is ongoing. So that's an important addition just from a practical standpoint. For all the prescribers out there. So just to wrap up this section, so a case study from the Opioid Use Disorder Practice Update. Arun is a 39-year-old male. He's coming to see you. He's trialed hydromorphone to support self-isolation when he was positive for COVID-19 and found it beneficial. He's interested in continuing his prescription. He's very concerned about overdose risk, but he's not interested in opioid agonist therapy at this time. On assessment, he has noticed a significantly reduced opioid use and reduced cravings on hydromorphone. He has safe housing with his partner. He has the ability to safely store his medication. There's no children there. There's no concurrent sedative use or alcohol use. He has previously overdosed, and he's very concerned about that. And his goal is to reduce his reliance on illicit opioids. So as the treatment plan goes, having a discussion on the patient's goals, motivations, collaborative planning. You and Arun decide together to continue with the prescription of hydromorphone with the goal of stopping illicit opioid use entirely. That's his goal. I think that it's really, really helpful to personally, I would say, in this prescribing, to set those goals up front. Whatever they might be, is really helpful during that assessment of whether somebody's benefiting down the road. Prescribing Arun oral hydromorphone, 8 milligrams, 1 to 3 tabs, QNH up to 14 tabs per day. An initial trial period recommended of 4 weeks with a scheduled follow-up appointment at the end of the trial period to assess if Arun's benefiting from the prescription. The practice update does outline 2 to 4 weeks as sort of that window to try one of these medications to see whether somebody is benefiting from it. But really important is a recognition that, especially some of these psychosocial benefits, they may take time to come around. And so 2 to 4 weeks is a guideline, at which point we hope to see some evidence that people are benefiting from these medications, but certainly in some cases more than others, it may take longer than that, and you get to use your clinical discretion, I think, to make that call. Here are some additional resources. I'll get to the questions in a second because I think we're at the end of the presentation almost. So the 24/7 line, if you have not called it before, it is 24/7. There are practitioners all around the province. It's not just a Vancouver line. They're all around the province who are on call at this number, 24 hours a day, 7 days a week, to provide to provide answers to your questions, or sometimes just to bounce challenging cases off of, because I know that for me it's just really helpful to to be able to discuss some of these trickier cases with somebody. So there's always somebody available through that line. For those of you who are more used to the RACE line, it's always available for physicians as well. These are just links to these various documents that are available on the BCCSU website. There's again that number for the 24/7 line. So just going to the questions here in the chat, a couple of really good ones here. So Patricia Caddy was worried that SA might be interpreted as short acting. We didn't have any say in defining what that code was, Patricia. I agree with you. I think that can be, I tend to write it very clearly, like this is for safe supply, no witness dosing. Like I have a whole narrative that I put in there, and I will include SA into that now. I will feed that back. I'm not sure whether this came from those who do the PharmaNet coding. So I hope that they have faith that this will be interpreted correctly, but it's a really good point to highlight. Barb, Eddie asking about once a patient's stable in OAT, do you try to reduce their hydromorphone prescription? That's a really interesting question. And I guess you're probably going to, I think that, I can provide my answer to that for what it's worth. And I think different people will give you different answers, is that I think that the prescribing of safe supply or special authority. That's a great comment. Also, a way that SA could be misinterpreted. I think for me as an addiction physician who prescribes safe supply, I do believe that this is the number one tool that we have that will hopefully help to reduce overdose deaths tomorrow. I do believe that there will be many unintended consequences to safe supply programs, some positive and some not positive. And I believe that in isolation, it's not going to be a panacea. It's not going to fix our problems, but it's the best tool that I have to try and keep somebody from dying in front of me tomorrow. But I think there's lots of challenges as an addiction physician being asked to be the gatekeeper for these medications. And I think it challenges us daily because we end up with, in some situations, we end up with scenarios that we can actually reconcile this prescribing with our traditional approaches to addiction treatment, with opioid agonist therapy, with methadone. We put them on a low dose of methadone, we supplement with hydromorphone, we titrate up their methadone to therapeutic dose, we wean them off of the hydromorphone, they're on a stable methadone dose, they're happy, and we kind of met our traditional goals. I think that there are many sorts of situations that challenge us much more than that, and you've highlighted one that is somewhat of a middle ground. So when somebody reaches a therapeutic dose of methadone, they're still on hydromorphone, and what do we do with that hydromorphone? I can tell you that my approach is the most important thing for me is that somebody is engaged and cared, that they're not using fentanyl, and they're not going to overdose and die tomorrow, and that they're feeling well. And so if continued prescribing of the hydromorphone on top of the methadone and helping to prevent that, then I am content with that. My preference would be, to have somebody on evidence-based treatment on a dose of methadone once a day, on something that is more traditional as far as what we know about addiction medicine and our evidence base. I think that is that would be my goal, I suppose, but my goal is not the most important one in the room. So I will often talk to people about whether they're interested in tapering their hydromorphone, about whether they're interested in just consolidating onto one medication they can take one time per day and feel well. But I'm also going to listen to the patient in front of me and what they need and what's helping them. And if they feel like this additional hydromorphone is a really critical part of them not accessing the toxic drug supply and again potentially dying, then that is good enough for me to keep it going. And it's just something that I check in on regularly and see where people are at. So we have and I'll just say that Guy has mentioned. Maybe you can chime in and talk about this a little bit yourself, Guy, because I would support you in that. I'm just going to read through some of these other questions.
Yeah, I was just, obviously, I appreciate the doctors that do it, and I understand the complexities and the challenges behind it. But what we really need is a non-prescriber model and, you know, the approval of DAM, and not just in injectable formulations, powder formulations, smokable formulations, because if you look at the amount of people that are dying, it's not from injecting the drugs, it's from smoking. And actually giving substance users a real choice. I mean, that's when it becomes to make a choice to actually get something that you know what you're taking. And like anything in life, you know, we don't go to the doctor to get a prescription for alcohol or cannabis. So, you know, for heroin, I don't feel the need that we should have to go to a doctor either. And so I think the challenges in our system is that you often have to look at, it's really easier to go to your drug dealer than it is to go to the health practitioner to get support. And that needs to change, because the amount of people that continue to die every day in our province and across the country. And if you look at 120 people in the country on heroin, I mean, it's just absurd. And if you look at what Switzerland's done, you know, there's evidence. We don't need any more pilot projects or announcements or false hope. What we need is a model that people can access and get access to it, so they can make, you know, an informed choice to purchase safer substances instead of, and if you look too, we don't shut down liquor stores when people become addicted to alcohol. You know, we don't go on a raid, like, you know, shut everything down. But yet for people who use drugs, this is what we've been facing, and this is what we'll continue to have to face. And sadly, more people will die because of it.
I can't agree more with everything you said, Guy. And I think that I mean, I think it's a really powerful indictment of us and of our system, that it's easier to just continue to go to your drug dealer and use drugs than to access treatment. If we make accessing evidence-based treatment, never mind safe supply, that much harder than just going to see your drug dealer, then it would be it's irrational for people to come seek treatment if we're really making them work that hard for it. So I think that's something that I think about every single day, and that we all need to keep in mind as prescribers. I know we're at time here, and I'm sure that we could probably carry on this discussion forever, but I want to highlight one other comment here, because I think it's a really important one. This is from Sandy Barlow. I'm just going to read it out loud. If the concerns of prescribers of possibly causing more harm than benefit on a whole community basis is continually discredited and ignored as anecdotal, there will continue to be challenges encouraging more people to prescribe, and some will stop as well. There are some prescription medications being given to those who they're not prescribed to, often the benefit to the person and being able to access a known substance in a low-barrier way, but there may also be potential harms to some others too. This all needs to be reviewed, discussed, and studied, such as possible questions in the Mercury BC Adolescent Health Survey, etc. We also need to continue to push back on the government and college, and strongly continue to advocate for real non-medically gate-kept safe supply, in addition to continuing with prescribed medications, OAT, and safe prescribed alternatives. And I think that really sums up almost all of my opinions in one comment. I think that there are real reasons that to be concerned about, or I shouldn't say concerned. There are real concerns that we need to be cognizant of when we're talking about such dramatic changes to public health policy and the way we deal with opioids. There will certainly be unintended consequences from this. As I mentioned, some of them will be net positives, and some of them won't. There are certainly people who are going to be harmed by these kind of broad policy decision or policy changes that are being made, and we can't ignore that, and we need to talk about that. And we because I often feel like we're having parallel conversations where advocates are talking about the benefits of accessing a safe and predictable supply, and critics or opponents are talking about potential harms, and both of those things are very real and need to be talked about, and we need to acknowledge that those can happen. Those can and in fact will both be happening. And so how do we find a way through this as a group? And I think it starts by acknowledging that, and by really having those discussions. as both Sandy and Guy have highlighted, I think as long as physicians remain the only gatekeeper to access these programs, it's going to continue we're going to continue to face enormous amount of challenges. And I think that another takeaway that many, if not all of us, have learned over the past 2 years is that we are not the appropriate venue to be the sole access point for these medications. It doesn't help. It doesn't help with access, and as long as we're continuing to try and do it this way, I'm speaking just personally. I'm very confident that safe supply is never going to be what many people want it to be. But I think that comment by Sandy is really insightful, and hopefully something we can close on. A couple other comments here. I also agree with these. Is that, Guy, thank you so much for. I feel like I've talked most of the time here, but I'm happy that you're here to share your experience with us, and you've been a tireless advocate. I just want to extend my appreciation for you being here again, and for you to continue to do all the good work that you're doing.
Thanks, Paxton. Thanks, everybody, and I hope I hope that we all can take a good look at how we address the crisis, and how we can reduce the harms, and really build connection and connection to people who really need support. So thanks again for having me. And
I think with that, please send your feedback on any of this, on any of the documents, to the BCCSU. We really would like to hear about questions or concerns that you have. We're all trying to learn through this together. And again, thank you for spending the time with us today. As always, I feel like the more time we spend together, the more we all realize how much we do agree on. And there's always going to be differences based on your own clinical context and your own region. But I find these discussions to be really therapeutic for myself, because it's really nice to have the opportunity to come together and share these frustrations, and recognize that we're all dealing with the challenges in our own ways. So thank you all for attending. I hope it was helpful. I hope that it was informative. And again, please do reach out if there's anything we can do to continue to refine this guidance to make it work for you.